Hi everyone, I will be talking about cystitis and uncomplicated urinary tract infection. I have tagged this as lesson 2, UTI lesson 2. If someone is asking me the question, where is UTI lesson 1? That will be pyelonephritis. So you can kindly check my channel for pyelonephritis, and that should be urinary tract infection lesson 1. So today I'll be talking about urinary tract infection lesson 2, and that will be about cystitis and uncomplicated urinary tract infection. Okay, let's go. So in individuals with cystitis, they will have dysuria, that is painful urination, urinary frequency, that is they'll be going to the washroom or toilet or giant depending on where you are on the surface of the earth, and of course urinary urgency. Okay, then they can have pain at the suprapubic region with or without pause in their urine, but they will not have fever, they will not have chills, no rigors, no fatigue, no malaise, and no flank pain. You can pause and go through that again. I will quickly go over complicated UTI just to be able to let you know that there is a wide difference between cystitis and just all other forms of urinary tract infection. In case of complicated urinary tract infection, there will be frequency, urgency, dysuria, hematuria is likely, pyuria is possible, flank pain. Remember I said you're not going to get this in cystitis. Fever, chills, rigor, vomiting, fatigue, malaise, suprapubic pain, and nocturia. Could see if you match this to the one we've just talked about, the previous slide, you will see the difference. When we are dealing with urinary tract infection, generally we should have this at the back of our mind that it's possible for us to be dealing with multidrug resistance, particularly gram-negative. We may be dealing with extended spectrum beta-lactamase resistance. We may be dealing with methicillin-resistant Staphylococcus aureus or even vancomycin resistant Staphylococcus aureus. Inpatient at hospital, long-term care home are prone to multidrug resistance, and some that are using broad-spectrum antibiotics or they have used that recently could come down with multidrug resistance. Travel to multidrug resistant regions could lead to acquisition of the organisms with multidrug resistant capability. And the examples that I have here are India, Israel, Spain, and Mexico. You are free to give your empiric antibiotics if it's uncomplicated and no multidrug resistant risk. Then you can start empirical antibiotic therapy without urine culture and sensitivity. That is why I've taken the time to go over what complicated UTI symptoms will be, just a quick rundown. You can check that slide, okay? And also what multidrug resistant risk factors will be, just a quick rundown. You can check that slide again. So when you have gone through both and you know, oh, this is not multidrug resistance case, or this is not a complicated case, then you don't need the gamut of investigations. You can just now start your empirical antibiotics right away. Okay, when you've ruled out complicated UTI, the person is not having that, multidrug resistant risk factors, none is in existence, then you are free to embark on empirical antibiotics right then you can choose any of these. Nitrofurantoin, leading here. Trimethoprim combined with sulfamethoxazole, that is Supra, for individuals that are not allergic to sulfonamide. But if the individual is sensitive or allergic to sulfonamide, use trimethoprim only. You can use Fosfomycin start dose, Pivmecillinam, Ciprofloxacin. I've talked about that before, depending on the age, not a pregnant woman, not breastfeeding woman, and not any child under 8 years. You can use Amoxicillin Clavulanate across the board. You can use cephalosporins like cephalosporin, ceftriaxone, and back to levofloxacin, also which is fluoroquinolone. The same condition that's applicable to ciprofloxacin is applicable here. You may or not include analgesics. If there is multidrug resistance likelihood, please wait for microscopy, culture, and sensitivity results before you administer your antibiotics or before you choose any of those. The other interventions that we can have is if there's anatomical or physiological anomalies, for example, neurogenic bladder or posterior urethral valve, bladder catheterization, nephrostomy tubes, or urethral stents, then pick up your paper and sign a consult to urologist. If this is involving a woman that is pregnant or involved OBGYN, okay? If that is the situation, then we're going to have more catheterization more frequently, and we'll change the catheter if the catheter is in place. But note this, I prefer 7-day course of antibiotics, so I don't have to bother about the immune status or comorbidities in my patients. But so many literature will say give some for 2 days, 3 days, 5 days if there's no immune suppression, if there's no comorbidity. So 5 to 7 days course of antibiotics is good enough. You can also generously hydrate, and that will help a great deal. If the individual is not vomiting, tell him or her to drink more fluid. Generous hydration will help urinary tract infections. Avoid nitrofurantoin in renal impairment. So if glomerular filtration rate is less than 30 minutes per minute, no nitrofurantoin, please. Fosfomycin is good for multidrug resistant cases or when there is contraindication to nitrofurantoin. Okay, and it's a start dose, just give it once. Trimethoprim, like I've said, if there's allergy to sulfonamide. No fluoroquinolones in pregnant and breastfeeding women and children less than 8 years. And with that, I've come to the end of urinary tract infection, and now I'll be moving to UTI lesson 3. So the end of UTI lesson 2. So someone having cystitis or uncomplicated UTI is handled here. Thanks for listening to my presentation. Kindly subscribe to my channel, and you'll be getting all these presentations immediately upon.